Okay, so I think we can continue. Dr. Francois, maybe she's at work or something.
Okay, thank you,
Dr.
Doctor.
Zuliat has joined, actually.
Okay, so today we'll start with I think we start at pneumonia. Yeah. So pneumonia is just an infection of the lung, inflammation of the lung. That's pneumonia. We have four different forms. mm, Four different forms: the lobar, the bronchial, the interstitial, and the cryptogenic organizing pneumonia. So lobar pneumonia is one of the commonest form of pneumonia that we have, and each of these pneumonia type have different organisms that are implicated in causing them, and they have different features on X-ray. So that's the way you can identify them, your X-ray and your microbiology culture. So for the lobar pneumonia, it's um on X-ray, it's actually associated with presence of homogeneous opacity.
Hi, sorry, Dr. Wale, are you not sharing your screen?
Oh, sorry, I forgot.
Okay. And they're recording too.
Yes, I'm recording.
Okay.
Okay. Can we see my screen now?
Yeah, we can.
Okay. So the lobar pneumonia, we can see the homogeneous opacity that's affecting part of the middle lobe and the entire lower lobe in this person's right lung. So that's the way lobar pneumonia present. It's more like an homogeneous opacity. That's what you see, and it's being caused by streptococcal pneumonia. That's the most common organism that is implicated in lobar pneumonia. So you get them from the nasopharynx. They become aerosolized. They travel down to the the alveoli. So by the time they get to the alveoli, they trigger the inflammatory response. You have the neutrophils, macrophages coming around. At the end of the day, you form an intraalveolar exudate, which brings about consolidation of the lungs. So at the end of the day, the lungs become indurated due to the presence of the exudate. So we talked about the cause of consolidation yesterday. Pneumonia is one of them. Pulmonary edema is another one. So the exudate of the bacterial, white blood cells, the fibrin, everything that comes together brings about hardening of the lungs. That's why they become consolidated. So when they get to the alveoli, they trigger this response. The white cells they come around, the platelets, the fibrin, everything are there. Some of these inflammatory cells can also pass through what we call the pores of corn. So they pass through the cause of corn, they leave that alveoli, they go to another one, to trigger the same mechanism, and through that process they can affect an entire lobe of the lung and also go to another lobe and affect it, and in the whole process they can even affect the entire hemithorax. So that's that about pneumonia. Most common organ that is implicated in it is streptococcus pneumoniae. You must always remember it, and what you see on X-ray is homogeneous opacity of a particular lobe or the entire lobes within that lung that you are looking at. So the other organisms that are implicated include Legionella and your Klebsiella. So bronchial pneumonia is another form. Bronchial pneumonia typically present on X-ray with patchy opacity. So you just look at the X-ray, you are just seeing some patchy opacity, more like what you see in your interstitial pneumonia, just like what you are seeing below for interstitial pneumonia. That is exactly what you also see in bronchial pneumonia. Similar thing like this. But the thing about bronchial pneumonia is that in most cases, it's not usually bilateral, like you have in interstitial here. So you just have, patchy opacity. You see some patchy opacity in one lobe. You see some patchy opacity in another lobe. You see in another, lobe. Maybe you see in the upper, you see in the middle. You also see in the lower. So it's not homogeneous. So that is actually in keeping with what you have in bronchial pneumonia. And the inflammatory process actually starts within the bronchial. The bronchioles of the airway then can spread down to the alveoli. So that patchy distribution gives it away. And the most common implicating organism is actually Staph aureus. So Staph aureus is a common cause of bronchial pneumonia. Streptococcus pneumoniae can also cause bronchial pneumonia, but Streptococcus pneumoniae is notorious for causing lobar form. Then H. influenza and also Klebsiella. So Klebsiella is central to both of them, lobar and bronchial. just like strep pneumo, but staph and Haemophilus are actually native to causing bronchopneumonia, where you see your patchy infiltrate on the x-ray. That is it. You don't have too much stuff about it. It's just the x-ray that gives it away. And you also need to know the type of organisms that are implicated in causing them. The third one is
So
intestine.
sorry. So in both, strep pneumonia is the one of the commonest, or all the organisms listed together. Any of them? Is there any like? Is there one that causes it more commonly?
Yeah,
Do you
so
understand?
like they are different. So for lobar, it is strep pneumo. That's the commonest
Mm-hmm.
for lobar.
Mm-hmm.
For bronchial, it's usually staph aureus. It's usually staph aureus.
Okay.
But
Okay. That's a distinction. Okay.
yeah, so but strep pneumo can also cause bronchial pneumonia. Just like Kleb can cause bronchial pneumonia and lobar pneumonia.
And
Do you
loba.
get it? So that is it.
Okay.
But
So if we are given the diagram, depending on whether it's a loba or broncho,
or
then it's
bronchial,
you know
exactly,
what's the most likely implicating organism.
exactly. So the way they also paint the Kleb one, they will tell you maybe the person is an alcoholic or the person is a diabetic. So
Yes.
they will try to give you pointers to immunosuppression, and they can also say in the history that the person produced this um red currant jelly, so you are just having mucoid sputum that is having tinge of blood, so you are thinking of cleb. So that's the way it is about your
Okay.
Klebsiella. uh
Okay.
so for
Okay.
interstitial pneumonia, you have this patching inflammation like you have in bronchial pneumonia, but it's bilateral. It affects both lungs. And in most cases, so you just see this bilateral multifocal opacity diffusely affecting the entire lung zones. And the implicating organisms here are actually not your bacterial. So they are not the common stuff that we know like the strep pneumo, the staph aureus. They're actually these organisms that we are seeing here: your mycoplasma pneumoniae, your chlamydophila pneumoniae, legionella pneumoniae, coxiella bonnetii, and the viruses. So the reason why they call them atypical is that they are not caused by the typical organism that brings about pneumonia, like the strep pneumo and the Klebsiella. So they are caused by the viruses and all these uncommon organisms like your chlamydia, your mycoplasma. And it's also known as walking pneumonia because this form of pneumonia is actually very indolent. It's not severe. So you can have a person having this particular x-ray pattern and the person is still walking, the person is not bedridden. So it shows that it's very mild and not severe compared to the other types. Because someone that has a bronchial pneumonia and lobar pneumonia will be coughing madly, they'll be dyspneic. You might want to admit them. So but in the interstitial form, they might still be working freely, and your radiographic picture is not in keeping to the severity of the physical symptoms. So you are thinking it's likely to be an interstitial pneumonia. It's very common for mycoplasma pneumonia. That's one of the pointers. So once you see them talking about diffuse patchy inflammation affecting the alveolar walls. And again, yeah, I should have mentioned that the inflammatory process actually localized to the alveoli only, to the alveolar walls only. It doesn't affect the bronchioles or the bronchi. No, it affects the alveoli only for the interstitial pneumonia, and it's not as severe as the other one. So you tend to see your bilateral opacity on your x-ray, and it's caused by the viruses, the respiratory syncytial viruses in children commonly, CMV in people that are immunosuppressed, influenza. People that have COPD can have influenza, causing the pneumonia. Then adenoviruses too are implicated in causing that. Then don't forget your atypical organisms like this mycoplasma, chlamydophila, legionella. Both all of them end with the pneumonia. Mycoplasma pneumoniae, chlamydophila pneumoniae, chlamydophila psittaci that is gotten from birth, and legionella pneumoniae. So the third one is our cryptogenic organizing pneumonia. So this is also known as bronchiolitis obliterans organizing pneumonia, bronchiolitis obliterans organizing pneumonia. Now, the way you able to identify this form of pneumonia is that you see someone that you know comes to you coughing.
Sorry, Dr. Babawali. These atypical pneumonia, they are not as bad when you see them clinically, but their lungs are like very bad, Abi.
Yes, this is what you see. You see this pattern on X-ray. So The lungs are bad. Yes.
So in the clinical picture, what the fever can be mild fever, right? But
Yes. It can be
the
mild fever. Yes.
the okay, and then it delays more in presentation than normal one, but the
Yes.
lungs picture will be very bad.
Bad. Yes.
Thank you.
You're welcome. So the cryptogenic organizing
Dr.
pneumonia.
Babawale, sorry, can we please look at the picture of the bronchopneumonia again? I want to see if I can see a clear distinction between the two images, the
No, you don't.
interstitial.
We don't actually have
Oh,
bronchial
we don't have a
pneumonia.
picture of broncho.
Yeah. So
It's
it looks
lobar
like
that we
this.
have.
It looks like this too. Let's see if we can get it on the screen.
Yeah, just in case we get an image.
Okay. So you, okay. I think we have something here. You can see all this opacity. You can see that they are not homogeneous, Dr. Francois. You can see them.
Mm-hmm.
Look at this now.
Not homogeneous.
Not homogeneous. It's like diffusely, it's patchy, just taken from everywhere. You can't circumscribe it that okay, this is where it's localized to.
Right.
So
Mm-hmm.
it's just everywhere. You can let me zoom out this. You can see the opacity here. You can see here.
Yeah.
Hmm? So that's the way it's
Yeah.
localized. So when you do your culture, you can actually from your sputum culture, you can culture the organism here. But if it's a case of the interstitial one, you will not likely get anything from your culture because
Mm, okay.
whatever is there, your chlamydia, your Coxella bonnetti, you can't culture those guys. So
Yeah.
and again, the severity, the presentation will not be very severe for your interstitial pneumonia.
Pneumonia.
Yes.
Okay. Thank you.
Yes, you are welcome. So the cryptogenic organizing pneumonia too, they don't produce sputum, just see them presenting with maybe cough, difficulty in breathing, fatigue, but they don't produce sputum because you don't have any organisms that is triggering that inflammatory process. So you don't have any pulse, anything to form mucus to stimulate production of the sputum, and they are usually culture negative because, like I said, there's no organism that is actually responsible for this. So studies have shown that majority of the cryptogenic, because when you hear something cryptogenic in most situations, it means you not being able to identify the cause, just like idiopathic. So um it has been linked to some causes like use of some chemotherapeutic agent, use of amiodarone. You guys know that amiodarone can cause lung problem, can cause pulmonary fibrosis. Um, some some inflammatory disease like SLE, like rheumatoid arthritis, has also been linked to causing cryptogenic organizing pneumonia. So it's actually characterized by inflammation of the bronchioles as well as the alveoli. So the terminal bronchioles, the respiratory bronchioles, and the alveoli are inflamed in people with the cryptogenic organizing pneumonia. And they don't, you know, if you try to, take maybe do a washout of the alveoli, you do your bronchoalveolar lavage to culture, whatever it's there, you won't get any result. If you give them antibiotics, they don't respond to it. So the only thing that you can use to slow down that inflammatory response is to give glucocorticoid. So they can still respond to glucocorticoid. So that's that about the cryptogenic organizing pneumonia. I just know that it's only localized to the bronchioles and the alveoli. The interstitial one is localized only to the alveoli. Your bronchial pneumonia is confined to your bronchi as well as the alveoli. So that's that about um, the COP, which is cryptogenic organizing pneumonia. Then let's move to aspiration pneumonia. So aspiration pneumonia is just a form of pneumonia that occurs following aspiration of oropharyngeal and gastric content. So let's say someone has gastroesophageal reflux disease and the person aspirates the gastric content, the person can develop aspiration pneumonia. Or someone that is unconscious, maybe someone that has a stroke or someone that has suffered a trauma, the person GCS is very low and the person cannot even control his airway, the person cannot, cough. That person is prone to aspirating. Someone that has dysphagia, probably the person has maybe a mass in the esophagus that is, obstructing swallowing. Due to that dysphagia, the person can have aspiration, because of accumulation of fluid and um, saliva, secretions within within the lungs, within the esophagus, or even food that can easily get back into the airway that is just anterior to the esophagus. So I've mentioned people with stroke. The stroke one is very similar to people with altered mental status. So both of them, they have suppression of the cough reflex, and they cannot even control their airway. So they are prone to aspirating. People that have invasive tubes inserted to them, like nasogastric tube. So if someone has a nasogastric tube, although some people used to believe that okay, nasogastric tube helps you to protect your airway. Yeah, but if someone is having an NG tube inserted into the nasopharynx through the esophagus to the stomach, there is a tendency of the person of destroying or making the esophagus sphincters, both the upper one and the lower one, incompetent. So by way of that, you can have reflux of the food from the stomach into the airway because of the introduction of the NG2. So, um, once someone has any of these risk factors that we've talked about, there's tendency to aspirate, and food, you know, oropharyngeal secretions, even gastric content can get to the lung. So oropharyngeal content is actually rich in bacteria. So the staph aureus, the cleb, they are there. So, and also the anaerobes, like the Fusobacterium, Prevotella, uh um uh which other ones again do we know? The Peptostreptococcal, they are there. They can easily get introduced into the lung, and they can trigger pneumonia. So the area of the lung where they are going to settle depends on the situation of the person in terms of the position. So if somebody is, they tend to settle at the most dependent side of the lung. So if there's somebody is sitting up and the person aspirates in that sitting position, the most dependent side of the lung in that person is actually the lower lobe of the lung. But it goes to the right lobe because the right main bronchus is actually shorter, it is wider, and is straighter than the left one. So it allows for easy passage of content that is coming from the GI to go directly to the airway because it is wider, it is shorter, and it is straighter. So if somebody is sitting, the most dependent portion is usually the lower lobe of the lung because the person is sitting. So the also oropharyngeal content or the gastric content can just go down to the right lower lobe. If somebody is lying down, the most dependent portion when someone is lying down is the right upper lobe. So the content just gravitate and settle within the right upper lobe if the person aspirates when lying down. And this can progress to form an abscess. So that's a bad one. So the inflammatory response occurs immediately. Those content settles there. Depending on what we are looking at, if it's a chemical, yeah, you can have chemical pneumonitis from the acid. They can burn that area. The person starts developing chest pain. You have white blood cells recruited to that area to try to eliminate those acidic component, and in the process, the person develop chemical pneumonitis. But in the phase of aspiration of oropharyngeal content, because of the high bacterial load, particularly the aerobes like the Staph aureus, the Kleb, and the anaerobes like the Prevotella, the Fusobacterium, they trigger inflammatory response. And the lung is actually, they are notorious for trying to wall off infection. So they try to contain those infection. The LD lung tissue, the LD lung parenchyma, try to contain those infections so that it doesn't spread to them. And in the process, they form cavity. So when they form the cavity, that leads to an abscess. So within that abscess, you have dead white blood cells, your dead bacteria and everything forming pus. So you tend to have what we call the gas fluid layer. So the gas that is present in the air and some of the gas that is being produced by these organisms, gravitating on the fluid from the decay of the bacteria, decay of the white blood cells and everything. So you tend to have a hair fluid level. So you see the hair looking dark, hyperlucent. Then you see the fluid looking, you know, white, like opaque. So we are going to see a picture um that will make us appreciate how a lungs abscess appears on the chest X-ray. So we've talked about the aspiration pneumonitis, which is a chemical one. So the chemical pneumonitis just appears hours after the aspiration event. So someone has a GRD, the person lies down at night, suddenly aspirates the gastric fluid, gets to the airway, the inflammatory response is triggered immediately, and the person starts complaining of chest pain, heartburn, and difficulty in breathing. So because of the fact that in this chemical form you don't have any organisms being implicated in that. So the major form of treatment is just supportive. You don't give antibiotics. So what you just do is just give the person oxygen and then try to place the person in a normal position to prevent further aspiration. Then you can give glucocorticoid to relieve that inflammatory response. So that's the basic way you treat chemical pneumonitis. You can give glucocorticoid to suppress the inflammation, give oxygen in case the person is desaturating, then you want to position the person well. Yeah, so let's talk about the natural history of global pneumonia. So global pneumonia is the commonest form.
About it with the aspiration, pneumonia, any organisms
Yeah, I've
that we
mentioned
should
them.
look out for.
I've mentioned them. So we are thinking of it's more like a mixture. It's actually a mixture of your aerobes and your anaerobes. Your aerobes and your anaerobes. The aerobes we are looking at include staph aureus and cleb. Staph aureus and cleb. The anaerobes we are looking at include your Prevotella, your Fusobacterium, your Peptostreptococcal. So Peptostreptococcal, Fusobacterium, Prevotella. They are all anaerobic.
Sorry, what's the last one you just mentioned?
Okay, so
The
bacteroides,
peptostrep.
Peptostreptococcal,
Yeah,
bacteroides,
bacteroides. Okay.
Prevotella, Prevotella,
Clevotella.
Prevo, P-R-E,
Prevo.
Prevotella,
Okay. Prevotella. Okay.
and the Fusobacterium. Mm.
Okay. And these are the which ones are these?
They are the anaerobes that can get into.
Anaerobes.
Yeah.
Okay.
So what you want to do is just to place them on antibiotics that have the broad spectrum. So the typical one that they use, minocycline. You can use clindamycin or minocycline. So
Slender or minnow. Okay.
I think it's Clinda that we use majorly. It's Clinda that we use. So Clinda.
Okay.
Yeah.
And then you mentioned the aerobes or
Yeah, aerobes, Staph aureus, Kleb.
okay.
Yeah, Staph aureus, Kleb. Hmm?
Thank you.
You're welcome. So the natural history, four stages of pneumonia. So that's a typical presentation of pneumonia. Within like 1 week, you have resolution of everything. So it starts with the congestion phase. So following that insult, what happens? Inflammatory response kick in. So what happens? You have vasodilation. You want to recruit, you know, your cells into that area. But that the congestion phase, you just have this vasodilation. You have more blood flow to that area. Your bacteria that is causing the pneumonia is actually what is predominant within the exudate. So at the congestion phase, you just have increased blood flow to that parenchyma, and the exudate that is there is actually rich in the bacteria. So by the time it's getting to the 3 to day 4, that's when you start having your neutrophils coming around. Day 3 to day 4, acute inflammatory response. So our neutrophils comes around because we've had enough blood flow to that area. So neutrophils are recruited, white blood cells, of course, neutrophils are white blood cells, and the red blood cells and fibrin, everything with the bacteria, they are being deposited at that area. So they are making up the exudate at the day 3 to day 4. So we call it red hepatization because at this stage we are having a lot of components forming the exudate. It's no longer entirely the bacteria. So you have the red blood cells there, the neutrophils there, fibrin being deposited from the platelet as well as the bacteria themselves. So you have a lot of things. The lungs are now looking very solid. So because they are solid, they are resembling how the liver looks like. So that's why they use the word hepatization. They are looking like the liver tissue at that point. So they are red because they are rich in the red blood cells. So we should take note of that. The congestion phase, more blood flow, there's congestion. The bacteria is entirely what is present within the exudate. By the time it gets to day 3 and day 4, your white blood cells are coming around, white neutrophils predominantly, alongside the red blood cells and platelets. From the platelet you have fibrin deposition. The red blood cells are there, the white blood cells. So everything is getting solid, and they are appearing red because of the red blood cell. Then by the time you move from day 3, day 4 to day 5 and day 7, you start having degradation of your red blood cell. The red blood cells is the particular component of this exudate that is impacting the color to the tissue. So they start appearing gray because the color starts becoming dull. So because of the degradation of the red blood cells. and as well as the fibrin. So at that time, you have predominance of your white blood cells because your macrophages are now trying to come in at that point. So your neutrophils, your macrophages are predominant there. They're also degrading and lysing out the red blood cells. So the whole lung tissue is appearing gray. So by the time you get to the end of the first week, which is about day 8 and beyond, the macrophages have destroyed everything that is within that exudate. The red blood cells are entirely gone. Your fibrin are totally mopped out. It's possible that some of this exudate has already been expectorated and swallowed. So you have clearance of those inflammatory response, and that's what you call the resolution. So you can have minimal scar or healing within that lung tissue. If there's going to be scar, it's going to be very, very minimal at the resolution phase. So that's the way it looks like. Congestion, more blood flow, predominantly your bacteria that is triggering or inciting that inflammatory response in day 1 to day 2. By day 3 to day 4, that's where you have your acute inflammatory process occurring. Your neutrophils are there, which brings about the white blood cell component, as well as your platelets and your red blood cell being around. So your platelet deposit the fibrin. So because of the red blood cell being there, they appear red. By the time you move from your day 3 to day 4 to 5 and day 7, your macrophages comes around, your neutrophils are still there, your macrophages start degrading the red blood cell, losing the red color, and it makes it appear gray. By the end of the first week, that is it's day 8 and beyond, you have total resolution of everything. Your inflammatory response is subsided, the red blood cells are taken out, the fibrin are taken out, even the neutrophils are dead. You can have minimal healing by scar tissue, or no even scar tissue, and the lungs get back to normal for later. So yeah, so we've talked about long abscess. You guys can see there's like repetition of what I've said. Long abscess just means you have collection of pus within a parenchyma, which usually follows aspiration. So follows aspiration of oropharyngeal content. So you guys are seeing that it's predominantly the oropharyngeal content that has been aspirated that brings about the formation of the abscess, not the gastric tissue. So it's common in people that are predisposed to loss of consciousness, like someone that is overdose on alcohol, or someone that is suffer a seizure attack, or someone having an obstruction. If there's an obstruction anywhere in the lung, particularly in the airway, like the bronchioles, you have mucus accumulating downstream to that obstruction. That's a very potential site for growth of bacteria. So they start multiplying and affect the lung parenchyma itself. You start having the cavitation, just like we've talked about. The cavitation, which is a response of the normal surrounding healthy lung tissue trying to contain the infection, preventing the spread. So with time, you tend to have degradation of the cells, making up those inflammatory response. So when the cells die off, they form the pus. You guys know that pus contains dead neutrophils, dead white blood cells. That's what is a major component of pus. So they then start forming the pus. That is why you have the fluid. Then the hair that is in the lung, settles over the pus, and you tend to have what we call the hair fluid level on your X-ray. So just like we can see here, looking at this um red arrow, so we can see area of hyperlucensin above that area. Then below it, you can see that white marking. So that white marking is talking about the abscess. That is the fluid, the pus within the abscess. So you can see the hair above it. So you have an air fluid level. That should not be a normal thing. You should not have fluid within the lungs. So using a hair fluid level, you are suspecting a lung abscess. You are suspecting a lung abscess. So what are the implicating organisms, especially when it's due to this aspiration of oropharyngeal content? Bacteroides, just like we mentioned, Fusobacterium, Peptostreptococcus, or Staph aureus for the aerobic. So you want to treat by giving antibiotics to clear it. But if it's a very large one, you might want to drain. Some might be very, very large that you might even need to go into the chest, doing surgery to evacuate everything, because your abscess will not resolve until you evacuate it. So you don't want it to cause entire lung damage before you go in. So you need to drain it if it's very massive and it's not something that can resolve with the antibiotics, or you do surgery. So lung abscess secondary to aspiration is commonly found in the right lung. I've explained why. If somebody is sitting up, um, it goes to the lower lung zone. If it's person is recumbent, it can either go to the right upper or the middle, but commonly the upper zone. Yeah. So that middle might be if somebody is recumbent and the person is lying on the right side. So if someone is recumbent and the person is lying on the right side, there's a high tendency of the person aspirating to the right middle lobe. But if the person is just lying down recumbent with the back flattening on the surface, you are not lying by the side, it's just directly. So upper. But if it's lying by the right side, middle. But if it's person is standing up or just sitting up, upper, lower lobe, lower lungs. So, do you guys get what I've said? I should come again.
Yeah.
Okay. All right.
Please let me repeat to see if I got it right. So you said that if the person is upright, because you are standing and gravity is acting, it will go to the right lower lung, right?
Yes.
The lower lobe. Then if the person is recumbent, it's more likely to go to the upper or to the middle.
Mm-hmm.
Okay.
Yeah.
Thank you. We got it.
So lung cancer. Someone that has a lung cancer, how will they present? So lung cancer is the leading cause of cancer death. We are aware of this, although it's not the commonest form. Mm. So, for example, in the male's prostate, in the female's breast, but the second most common for both of them, lung. Then um for the third, colorectal. So that's the way it works. Um, what do I want to say next? But the most killer cause of death, for cancer, lung cancer, it's the most notorious when it comes to mortality. How would they present? Cough, hemoptysis, especially when you have that malignancy rupturing into a nearby vessel, they can present with hemoptysis. You can have obstruction of the airway, particularly when you have it centrally located. So, Dr. Juliet, someone has a bronchial obstruction. What complication out of what we talked about yesterday do you think can happen? Bronchial obstruction.
The athletics.
Yeah, Dr. Juliet, be confident with it now. Ah,
Athletics.
yeah. So the atelectasis, the obstructive atelectasis. So you have an obstruction. The remaining hair within that alveoli will be absorbed. So they will collapse at the end of the day, and the person
Collapse,
develop
yeah.
atelectasis. So atelectasis is one of the fear. Then what else? Based on what we have said, bronchial obstruction. What else can happen again?
Aspiration.
Not really. I did not link it to aspiration. Aspiration is separate. Bronchial obstruction is another thing. Both of them can lead to what?
Um, I really don't know what you want. I don't know what you want. I'm thinking far right now.
Okay.
Um,
We just talked about something now, and we said
Protectors.
is
aspiration
it
causes something. Hmm? Bronchial obstruction, I said it causes accumulation of mucus downstream that obstruction, which will lead to development of the what? Abscess, right? That's what I said.
abscess? Yes, abscess, lung abscess.
So, bronchial obstruction causing abscess is not due to aspiration. Do you get it?
Okay, so it is due.
Say it
Please,
again.
can
I
you
didn't get
just
that.
repeat it, please?
So, when we're talking about abscess, now we said it's caused by aspiration of oropharyngeal content, especially people with this, or bronchial obstruction. Can you guys see that? Bronchial obstruction or aspiration. Both of them can cause abscess. They don't work by the same mechanism. Aspiration is when you're taking it, when you are taking it from the oropharyngeal region to the airway. Bronchial obstruction is you're obstructing that airway. Mucus is accumulating distal to that obstruction, and the abscess can develop from there.
Okay. Sorry.
All right. So, bronchial obstruction, both
But
as
there
we
was
said,
something you said now that something does not happen because of something.
And
yes,
because me, I want to give example of cancer obstruction that is going to be causing aspiration. It's not that it's causing aspiration, it's actually that it can cause lung abscess.
exactly. That is it. So,
Okay, now I get.
um, guys, we need to move. I need to finish before 6. So, um, another thing, they can have wheezing. So, from the bronchial obstruction, one of the predominant way they will present is wheezing. that wheezing breathing because of the bronchial obstruction. Sometimes you might do X-ray and incidentally you might detect a non-calcified nodule on CT, or you can see a coin lesion, just a round, lesion on your X-ray. So that's likely to be a lung cancer. If you do repeat of um that radiograph or the imaging and you are still seeing that nodule and it's not expanded, it's not enlarged, it's not likely to be a lung cancer. It's likely to be maybe an hematoma or a granuloma. But if there is enlargement of the nodule with time, that's a lung cancer that the person is dealing with. So what are the signs of metastasis of lung cancer? The code is lab, LABB, our laboratory. Liver, number one, they present with jaundice, hepatomegaly, adrenal glands, adrenal insufficiency. It can go to the bone, they can have pathologic fracture, then it can go to the brain, focal neurologic signs, seizures, and all those things. So majority of the lung cancer actually develop from metastasis. They are not primarily developing from the lung. Majority of them are from metastasis. So, and what are the types of metastasis? Where do they come from? Most commonly, the breast, the colon, the prostate. Don't forget those three, very important. BCP, biology, chemistry, physics. BCP, breast, colon, prostate, they typically go to the lung. Very important. Breast, lung, colon, lung, prostate, lung. So it's different from the site where the lung metastasizes to. So where the lung metastasizes to is the lab. Goes to the liver, goes to the adrenals, the bone, the brain. But where it comes from is the BCP. So breast commonly goes to the lung, the colon goes to the lung, the prostate goes to the lung, and the bladder. Okay? Bladder is not very high, but if you want to know it, you can learn it. What are the complications for lung cancer? So the acronym is SPHERE. SPHERE. S is standing for supravenous cava obstruction. We'll talk about it very well. Pancreas tumor, we'll talk about that too. So pancreas tumor is when someone have this lung cancer emerging from the apex of the lung. That's a very bad position. Horner syndrome is also one of the complications of this pancreas tumor. We'll talk about it. Endocrine. So we know lung cancer have paraneoplastic manifestation. We have to know all of them. It can also compress on some nerves, like recurrent laryngeal nerve, the phrenic nerve, very important. So someone that has compression of the recurrent laryngeal nerve, hoarseness of voice, the phrenic nerve can have difficulty breathing or elevation of the diaphragm. Okay, they may spread to adjacent, pleura, and the person can develop a pleural effusion. So, Dr. Oluwatobi, what type of pleural effusion will this person manifest with? Someone that has a lung cancer.
Transudate.
Can I try exudative now? Okay.
Exudative.
Exudative.
So, Dr. Zuliat, what did we say are the causes for transudate?
Sorry, I was away from my phone. The causes of transudate will be what's it called? Exceptions of malignancy, infection, and all that. That's there are two things. Yeah, yay, it's not coming to my head, but I
Nephrotic
know that.
syndrome, hypoproteinemia, and this thing.
We talked about things like
Hypoproteinemia and increased permeability of the
No. There are two things.
Exudative. Anything that will increase capillary hydrostatic pressure now.
yeah,
Yeah, that's
Or
liver
reduce
failure.
oncotic pressure.
That's
exactly.
cirrhosis and one more thing.
Guys, I want you guys
Oh
to
wow,
focus
but
my
that's an option.
Things like congestive cardiac failure,
congestive
low
cardiac
protein.
failure, congestive kidney
Yeah,
failure,
kidney
transudate.
problem or something.
If someone has a nephrotic syndrome, the person is losing protein, transudate. If this person has a liver
Protein losing
cirrhosis,
enteropathy.
protein losing enteropathy, transudate. So the other ones will be exudative, something that will damage the capillary endothelium. Malignancy, infection,
Infection.
trauma, pancreatitis, anything you can think of. Only those transudative ones. And do you guys remember the light criteria that we talked about yesterday? Dr. Abisola?
Yes.
So, Dr. Abisola, what are the components of light criteria? We are forgetting light
Should
criteria.
I try?
Light, I still remember that
Yeah,
one.
Dr. Lushola, light criteria.
Well, when we have the component will be the pleural fluid LDH,
Okay.
where we said the transudative is if it's less than two-thirds of the upper limit of normal LDH, then it is exudative, it is greater than the two-thirds of the upper limit.
Mm-hmm.
Where you said, let's say it is one,
Okay. No,
greater than two-thirds will be
don't give example
upper.
so that I will not waste time. You get
Okay,
it. I know
then
you
the
understand.
other one we have is the ratio of pleural fluid protein
Okay.
to the serum protein.
Yeah,
Okay. Okay.
that's okay.
So that one, it is transudative if it's less than or equal to 0.5,
Yes.
then exudative if it's greater than 0.5.
Okay. So what's the third one?
Then we have the third one, pleural fluid LDH
Yes. Yes.
to the serum LDH,
Mm-hmm.
the ratio.
Mm-hmm.
So that one is 0.6.
Yeah,
Less than
0.6.
or equal to 0.6 is transudative,
Okay.
and greater than is 0.6 for exudative.
Exudative. Dr. Oluwatobi, have you refreshed, your memory now? Dr.
Yeah,
Oluwatobi.
thank you.
So don't
Thank
forget it.
you.
Yeah, so it can spread to the pleural, it can spread to the pericardium. Hmm? They are very close to the mediastinum. So the pleural, the pericardium is just within the mediastinum. That's the heart. So you can have a fusion there too. So what are the risk factors for lung cancer? So don't worry, guys. When we start talking about this pancreas and everything, you understand this complication. You might not even need to memorize this fear everything. So what are the risk factors that can cause lung cancer? The number one there is tobacco smoking. Smoking, number one. Number two is radon. Radon gas exposure, number two. Then people that have second-hand smoking exposure, radiation, ionizing radiation, environmental exposure to like radon, like we've talked about, asbestos. So if someone has asbestos, what tumor are we looking at, Dr. Oluwatobi? Asbestos,
Mesothelioma.
mesothelioma.
No, bronchogenic cause. Are we?
Yeah. That's very
Oh,
good. So you guys,
bronchogenic.
you guys are correct. That's very good, Dr. Zulia. Thank you for reminding us that. So bronchogenic first, but it is only asbestosis that is associated with mesothelioma. That's a very good one. Thank you. So pulmonary fibrosis. We mentioned it that day. Pulmonary
Sorry,
fibrosis.
can you mention your last statement again? That it is only.
Asbestosis is the only cause for mesothelioma. Asbestosis is
Oh,
the
okay.
only
Thank you.
cause. So
Thank you.
Dr. Zulia, do you want to quickly tell us what you are going to see? Asbestosis. What are you going to see? That can give you suggestions for asbestosis.
Is it the ferruginous?
Ferruginous body.
The
Ferruginous body.
yeah,
Ferruginous body.
mm,
So dumbbell shaped body that are, proteinaceous. They contain protein, they contain iron.
potentials.
They contain iron. So because of the iron component, you tend to stain them with the Prussian blue stain. And you are going to see them.
Yeah.
Don't forget. Iron Prussian blue.
Um,
Iron Prussian blue. Ferruginous body. You can see it from someone that is building cheap, someone that works in a roofing industry, someone that works in a plumbing company, someone that works as a mechanic. Don't forget. Okay. Pulmonary fibrosis. So anything that can cause pulmonary fibrosis can cause lung cancer. We've talked about this. That is why someone with idiopathic pulmonary fibrosis can progress to developing a lung CA. So family history is also a pointer to developing, is a risk factor also to developing lung cancer. So what are the types? The very common ones that we know, squamous and small cell carcinomas. They are central, meaning that if you look at the chest like this, if you look at this city now, if you say it's central, that means that it's actually arising from the ileum, like the area of the ileum where the bronchioles are entering into the lung parenchyma. So somewhere here, that's where you have a central lung TA. So you might tend to have the typical presentation of the wheezing, the bronchial obstruction in a central tumor rather than from a peripheral tumor. A peripheral tumor will be located outside here, just close to the chest wall. Can you guys appreciate my cursor where I'm showing? Can you guys see it?
Yes.
All right. So that's where it is. So yeah, so both of them, the squamous and the small cell, they are shared with tobacco smoking. They share with tobacco smoking, both of them, and they are both central in terms of their location. So I've talked about someone having a nodule on the city, you know, that is not enlarging with time. So that could just be an hematoma or um, a granuloma. So I'm coming, guys. Just 1 minute. Yeah. So that hematoma or granuloma. Don't forget that. So hematoma are like benign malignant benign tumor. Why am I saying malignant? Benign tumor that is composing of cells, you know, where we are looking at. So you see like benign masses that are looking like, you know, tissues of the lung. They are not that they don't have any malignant potential, they are just there. So what are the types of the cancer that we have from the lung? We classify them into two types: the small cell and the non-small cell. The small cell and the non-small cell. Now we are separating the small cell because it has some distinct appearance, and small cell is very aggressive. It's a very bad one. Number one, in terms of location, it's central, just like we've talked about. It's also known as the old cell carcinoma. It is undifferentiated. That is, it doesn't look like the tissues of the lung. They don't differentiate along how the lung cells, the alveolar cells should look like. So they don't have this squamous cell appearance and all those things. For if they around if it's coming from the alveoli or maybe the pseudo uh the stratified squamous pseudo stratified squamous, you know, pseudo stratified columnar epithelium that you should have if you are looking at the tracheal or the bronchi. So it will not look like those cells at all. It will be completely differentiated. It will completely be different from them. So that's why we call it undifferentiated form. It's very aggressive, very aggressive tumor. It's very difficult to control too. You might need to, you know, use radiotherapy combined with chemotherapy, you know, before they can respond. So, and I share with some paraneoplastic syndromes. In fact, there are many. There are very many. Majority of them are neuro, while some are endocrine. So the endocrine one, we already know them. Those are the ones that start with the A. So the ADH as well as the ACTH. So they can cause Cushing syndrome and they can cause SIDH. So the neuro one includes the Lambert-Eaton myasthenic syndrome. That means you have the antibodies from this malignancy attacking, you know, the L type calcium channels within the presynaptic region of the nerve. So preventing release of calcium. So calcium can cause release of acetylcholine, which brings about paralysis. So you guys know how to differentiate these from myasthenia gravis. We already talked about it. So the autonomic symptoms, the are present here, then you tend to have, you know, problem with the reflexes here. Lambert-Eaton. You should pay attention to that. So small cell is a pointer to that, just like thymoma is a pointer to myasthenia gravis. Then you can have what we call paraneoplastic myelitis. So you just have paralysis of the particularly the lower limbs without any problems with the bowel or bladder control. That's your paraneoplastic myelitis. Just like you're having a spinal cord problem, paralyzing the lower limbs, you know, without any problem with the bladder or the bowel. They are intact. So they can have paraneoplastic encephalitis. This one is common. So majority of all these ones are actually share with production of antibodies towards U protein. There's something we call HU protein. By the time we are doing pathology, you guys will understand the features of this paraneoplastic manifestation very well. But for small cell carcinoma, it's actually due to antibodies against U protein, HU antigens. So that is what is causing all these myelitis, encephalitis, and this cerebral degeneration. So the encephalitis problem with the, you know, brain parenchyma, so they can have, you know, so many problems, but the most predominant one is memory. They have short-term memory issue. They can have seizures, they can have psychosis, sleep disturbances, so many problems. You know, encephalitis, that's the way they present. So psychosis, sleep problem, cognitive deficit like memory issues, you know, psychosis, um, personality changes, and all those things. Then subacute cerebral degeneration. So this is not subacute combined. This is subacute cerebral only. So they just present with cerebral problems. You're having antibodies destroying the Purkinje cells of the cerebellum. So they can have balance problems, ataxia, they have diplopia, they have vertigo, they have nystagmus, they have dysarthria, they can't swallow, dysphagia, so many problems, cerebral degeneration. Then endocrine, you've talked about that, Cushing and SIDH, and the oncogenic problem that is actually with small cell is actually amplification of the mic. So it can be any of the mic, but I think it should be the predominantly the C mic, that is amplified. Just know that mic oncogene is amplified rather, sorry, in someone with small cell carcinoma. So you want to manage with both chemotherapy or radiotherapy in case the person is not responding to your chemotherapy. So it's actually a neoplasm of neuroendocrine cells. So there's something called the Korczewski cells. They are neuroendocrine cells within the basal membrane lining the epithelium of the lungs. So we call them the Korczewski cells. They act like neuroendocrine cells that secrete some hormones. So they can secrete serotonin, they can secrete substance P, they can secrete histamine. So when they have abnormal proliferation of these cells, you can develop the small cell carcinoma. They appear small, round, dark blue. So that's why, small cell carcinoma is part of these small, round, dark blue cells. These are what you see on histology. This is what it looks like. These small, round, dark blue cells. Can you guys see it? Though it's not me. I cannot really, appreciate it from this. Although, well, they are looking distinct, but it is just how it looks on histology. Can you guys see it?
Yeah.
Yeah. So small, round, dark blue cells. It's not only small cells that look like this. Even someone that has rhabdomyosarcoma. So what other one do you guys know? Small round dark. I know you guys should know this one. You've done it a lot of times. Small round dark blue cell. Where again can we see it?
Eric sarcoma.
Ellen sarcoma.
Exactly. I know you guys remember it. So Ewing sarcoma. Ewing sarcoma.
Is
Kuchin
it also found in neuro? There's
Neuroblastoma.
neuroblastoma. Yeah.
definitely.
Neuroblastoma.
They contain neuroendocrine cells. Neuroblastoma, very correct. So that's why they share some markers in common. So the markers that are peculiar to these neuroendocrine cells, your chromogranin A, your synaptophysin. So your chromogranin A, synaptophysin, don't forget that. Neuroendocrine tumors, chromogranin A is always positive in them, then synaptophysin. Then you can have the neuron-specific enolase in someone with small cell as well as someone with neuroblastoma. So small cell has the three: chromogranin A, synaptophysin, neuron-specific enolase. Just like we have calretinin and cytokeratin in where?
Come
All these
again. Squamous
myofilament.
cells.
Just like we
Squamous
have.
cells.
No. I want you guys to
What
come
did
in.
you say?
Please, can you repeat yourself?
Calretinin, calretinin, and cytokeratin 5/5 and 6. Cytokeratin 5 or 6. Calretinin in which malignancy? That malignancy has
Mesothelioma.
mesothelioma. I'm not sure Dr. Francois was in that lecture.
No, I was in mesothelioma. I was in that one.
Yeah.
That's why I like it.
Okay. Mesothelioma. We should not forget that. I mentioned it that day. I said it that is what you can use to differentiate it from other carcinoma. It's only positive in your, mesothelioma. Separate it from the other carcinomas. Mesothelioma, carotene, and your cytokeratin. Cytokeratin is actually native to epithelial tumors. So cytokeratin, carotene, it contains, if you look at electron microscopy, you are going to see desmosomes. You are going to see microvilli. And I told us that day, desmosomes are surrounded by tonofilaments. So your tonofilament and your desmosome are actually helping you hold the intermediate filament in the mesothelioma. What are the intermediate filament they are holding? Our what? Cytokeratin. You cannot forget it. That is it. So
Sorry, please come again about that thing with the tonofilaments and the desmosomes.
desmosomes, they are like adherent, they are like all these adhesion, molecules. So
Yeah.
desmosomes are surrounded by the tonofilaments. So that is why
Okay.
part of what you see on the electron microscope includes desmosome, includes tonofilaments. So they help us hold those intermediate filaments together. What are the intermediate filaments we are talking about particularly? The cytokeratin. So which is
Okay.
present in mesothelioma. So if you can connect it like that, you will not forget. So your desmosome and your tonofilament helps to hold your cytokeratin together. Hmm? You should
Okay.
also take note of that keratin because we are going to mention it here too very soon. Keratin is squamous. Once you get keratin, anywhere, squamous, keratin, squamous, skin, because it's present in skin, squamous, keratin. So that's that about the small cell carcinoma. We should not forget it's a neuroendocrine tumor. You see the small round blue cells, they are specific. They stain positive for chromogranin A, the NSE, neurospecific enolase and synaptophysin. Okay. Um, the non-small cell. So adenocarcinoma is very interesting. So adenocarcinoma is very interesting. Um, it's the only one. It's one of the malignant that is peripheral in location. It's actually the commonest. So don't be deceived that squamous or small cell that we commonly say. The commonest is actually adenocarcinoma. It's very common in someone that is smoking. So if they give you an history of somebody that's having presentation of a lung mass, lung cancer, and the person doesn't smoke, you don't want to think about squamous cell, you don't want to think about small cell, you want to cast your mind towards adenocarcinoma. You just keep looking for clinicals to nail adenocarcinoma. And it's common in females than male. Small cell is common in males that are smokers. Males that are smokers, small cell. Females that are non-smokers, adenocarcinoma. And overall, adenocarcinoma is the commonest. The activating mutation in small cell is what? The CMYC is the activating mutation, the CMYC. But in the adenocarcinoma is a typical one that we know. These are the typical ones that are listed in pathology, the pathology section. The KRAS, the epidermal growth factor receptor, and the ALK. So the ALK is actually the anaplastic lymphoma kinase. But I don't think we need to know, just know ALK. ALK and EGFR code for a receptor tyrosine kinase. So that is what they do. They code for a receptor tyrosine kinase that drives that proliferation. KRAS, KRAS is just KRAS is for colon cancer, pancreatic CA, and lung cell. You guys must know it. I don't know how we code it, but once you see it, KRAS, pancreatic, colon, you know, especially that adenoma sequence. Do you guys remember that adenoma carcinoma sequence when we are doing GI?
Yeah.
You remember
Yeah.
that KRAS is one of those implicating molecule before T53 now does the finalization. You remember KRAS is
Yes.
one of them.
Yes. APC
KRAS.
plus and TP53.
Fantastic. So
APT first, KRAS, then P53.
yes. So KRAS, your EGFR, and your ALK. That's for your adenocarcinoma. Hypertrophic osteoarthropathy is associated with this guy. Now I'm going to pause this. So from the fact that we've called it adenocarcinoma, adeno means glandular. So that means that anything you are going to be seeing on your histology will be looking like glands. So when you do your biopsy, you are going to see glandular structures. And of course, glands secrete mucus. They can secrete mucus because, glands of the lung, mucus, goblet cells. So mucin secreting. So they stain positive for mucin. Don't forget that. Once you see them painting history, a non-smoker, female, this mutation, you know, on biopsy, glandular pattern that stains mucin. That is it, adenocarcinoma. So it has some subtype that we call the bronchoalveolar subtype. It's actually an adenocarcinoma in situ. So it's more like an adenocarcinoma in situ. So it has not breached the basement membrane, and it's actually confined to the alveoli wall. That's where you see. So it causes apparent thickening. It causes thickening of the alveoli wall. So you are just having this tumor cells growing within the alveoli wall, but they've not breached the membrane of the epithelial lining. So you just see tall columnar cells that are secreting mucus. That's the alveoli subtype. You actually have the mucus secreting and the non-mucus secreting subtype, but I think they want us to focus more on the fact that the mucus secreting one are common. So that's it. So what do you see on chest X-ray? You see AZ infiltrate that's similar to pneumonia. So that's your bronchoalveolar subtype. That's why they call it bronchoalveolar subtype. You know, you just see your infiltrate on your chest X-ray that looks like pneumonia, and on gross examination, you are going to see like thickening of the alveoli wall. When you look at it, your examination, you see thickening of the alveoli, on your microscope rather, you are going to see thickening of the alveoli wall, and you see tall columnar cells that are secreting mucus. and they are not showing features of invasive carcinoma. So you cannot call them adenocarcinoma. So when you see cells that um they are showing dysplastic features, you see prominent nucleolus compared to the cytoplasm, you are seeing abnormal, shape of the cell, abnormal polarity, dysplastic features, and they've not breached the membrane, the basement membrane. That's adenoma inside too. And you are seeing tall columnar cells that are secreting mucus. You are thinking of a bronchoalveolar subtype of um, adenocarcinoma. So let's go to the squamous cell. Squamous cell is central, just like um, our small cell. It, I share with the hilar mass. That's where they can cause the obstruction at the main stem bronchus. So you can see they arise from the bronchus. That's it. So that's why they are called central. They cause cavitation. So you just see um, like area of necrosis within that lung. So that can be filled with gas. So that's a cavity. So that cavitation thing is very predominant with squamous cell carcinoma. Cavitation, just see cavitation within that perialar region of the lung. Is associated with smoking, and its own neoplastic manifestation is what? Release of PTH related peptide. So it is not PTH, but PTH related peptide. You can see both of them in the option. Please don't go for PTH. PTH related protein. That is what is causing the issue, the pipe hypercalcemia. Okay, so what do you see? Because they are squamous cells, you see keratin pearls. That is it. Keratin pearls that are connected by the intercellular bridges, that which is the desmosomes. So keratin pearls. Once you see keratin pearls, you are thinking of your squamous cell carcinoma with intercellular bridges, which are the desmosomes. Keratin pearls with intercellular bridges, squamous cell carcinoma. Okay. So the second to last is large cell carcinoma. So this is a cavitation. This is an example of a cavitation. We can appreciate this. Guys, can we see this? Hello, guys.
Yes, we can see it.
Exactly. So these are the cavitations. This second one before it is actually talking about the adenocarcinoma. So these are like glandular structures, that's the way they look like. Adenocarcinoma. These are the so this one this D is actually the keratin pearls.
That's it.
Looking
Mhm.
like looking at what does it look like? It looks like some of our bodies are
Wall, yeah. It's
Onion,
looking like
onion.
a wall.
a wall,
Yeah.
exactly, a wall appearance.
Mm.
So that is keratin pearls. That's the keratin pearls. And um yeah. So let's go to large cell carcinoma. It's peripheral, just like the adenocarcinoma. It is highly anaplastic, undifferentiated tumor. That's like tautology. And anaplastic is not differentiated at all. Another one that is not differentiated is what? Which one is also not differentiated?
Small cell.
Small
Small
cell.
cell.
Small cell. You are seeing the
Awesome.
adenocarcinoma secreting mucus. It shows that it's differentiated. It's looking at the globular cells. It's differentiated. But the small cells are not differentiated. Now, the way you make diagnosis of large cell is that once you do your biopsy, it's more like a diagnosis of exclusion. And you are seeing features that is not in keeping with your small cell, and is not also in keeping with your adenocarcinoma. That is, you are not seeing glandular structures, and you are not seeing squamous cell structures. You are looking at a large cell carcinoma. So what you typically see is just presence of pleomorphic Gantt cells, you know, macrophages, that are looking enlarged, like something that looks like macrophages enlarged. These are the Gantt cells. Mm. So once you see in the history telling us histology findings of pleomorphic Gantt cells, that's large cell. That's how the name came by. Gantt cells on histology. That is our large cell. Is the diagnosis of exclusion? You are not seeing features of squamous. You are not seeing features of small cell. You are not seeing anything that looks like your Kochitskin cells. Then at the same time, you are not also seeing features of squamous cell. You are not seeing your keratin pearls or desmosomes, and you are not seeing features of adenocarcinoma. You are not seeing any glandular structures that secrete mucin. That is, that here you are likely dealing with. It's a very undifferentiated tumor. It is also strongly associated with smoking. The only one that is not associated with smoking is adeno. Latiel is associated with smoking, and it can secrete HCG, which can cause gynecomastia. So its own paraneoplastic stuff is just to be releasing HCG, which can make the person gynecomastic, and the person will have an enlarged breast. It's not responsive to chemotherapy. You'd have to remove it surgically. It has a very bad prognosis, just like small cell. Both small and large, they have bad prognosis. But surgery is the definitive treatment for large cell carcinoma. So let's go to the last one, the brocal carcinoid tumor. Now, carcinoid tumor are also neuroendocrine tumors. They also contain the neuroendocrine cells that secrete hormones like serotonin, histamine, substance P, and the likes. It's typically present in the gut. So the typical presentation of this carcinoid tumor is just neuroendocrine cells within the gut that secrete all the serotonin, histamine that are being secreted into the venous blood of the gut. Because of the fact that venous blood of the venous blood of the gut empties, some of them empties to the superior mesenteric vein, and we know that the superior mesenteric vein empties into the splenic vein. The splenic vein joins with the um uh SMB, that is superior mesenteric vein, to form our, what's it called, our
IVs.
hepatic portal vein, not IVC, hepatic portal vein. Splenic vein joins with superior mesenteric vein to form hepatic portal vein, which takes it to the liver, right? So that means that anything that has been emptied into the superior mesenteric vein, will find its way to the liver. So these guys don't actually present with carcinoid problem because serotonin that's supposed to be causing the problem will get to the liver first and it will be cleared. So someone can only develop, me and Dr. Oluwatobi talked about this like 2 days ago. So you can only develop carcinoid symptoms from someone that has a carcinous malignancy or a carcinoid tumor within the gut only if there's metastasis to the liver. So if there's metastasis to the liver, there's destruction of the liver cannot metabolize the serotonin again, they cannot clear it. So they are dangling in the blood and they are causing the problems. Or someone can have problem of carcinoid syndrome without having it present in the lung, only if it's present in the lungs. So if it's present in the lungs, you don't need metastasis. When they are in the lung, they can get directly into the systemic circulation and the serotonin there can cause all the problems. Yes, I know I've mixed up a lot of things, but I don't know if you guys get,
No,
what.
I think
So
I
we
get.
got you. We
Okay.
got you.
So,
I mean, cancer syndrome usually occur only when it metastasizes. Is that not what you're trying
yes,
to say?
because majority of them start from the gut. They actually located in the gut. It's only few that you see in the bronchioles. So when it's in the gut,
So,
that means,
or it is primarily in the lungs, Abby.
yes, yeah. But the ones that occur in the lungs, in the bronchioles of the lung, you don't need them to metastasize. They can empty into the
Mm-hmm.
vessel there and it will get to the systemic circulation.
Straight up.
But in the lungs, in the gut, because of the gut still empties into the liver will clear it. So they will not have any problem unless they metastasize to the liver, that is it. So the bronchial carcinoid symptoms are central or peripheral. So they can be central, they can be peripheral. They have good prognosis. Metastasis from there is very rare. So what do they cause? They can cause mass effect. So when they have mass effect, that means they are occluding that bronchus, and they will have symptoms like wheezing, mass effect, occlusion. Or they can cause carcinoid syndrome. That's when they now produce their neuroendocrine secretion, which now gets to the systemic circulation and cause all the symptoms. So serotonin is notorious for causing flushing, vasodilatory effect of serotonin, increased blood flow, flushing. It also triggers diarrhea. The last thing is bronchoconstriction causing wheezing. So this wheezing can be due to mass effect or it can be due to bronchoconstrictive effect of serotonin on the airways. So those are the typical way that they present. Flushing, diarrhea, bronchoconstriction. Then you can start talking about the damage that they cause to the lungs, which includes what and what, guys? What are the damage they cause to the lung? Carcinous syndrome. Sorry, I said to the lung, to the heart. Sorry, to the heart.
Tricuspid regurg.
Tricuspid.
Pulmonary what?
Right-sided heart failure.
Tricuspid.
Tricuspid.
Pulmonary hypertension.
we are sure we are sure saying different kind of things.
I said tricuspid regurg.
Yes, tricuspid withdrawal and
Hypertension.
it will be more pulmonary stenosis. It will be stenosis. So they cause fibrosis of those right-sided tissue. So that's why it causes the stenosis. Stenosis might not cause hypertension because blood will not even get to that artery. It will have been stenosed at the valvular level. So pulmonary stenosis and tricuspid regurgitation. You guys remember that when serotonin gets to the pulmonary circulation, it gets metabolized also, just like in the liver. So that is why it cannot cause a left heart problem. It cannot cause a left heart because before they get to the left side of the heart, they will have been cleared off. But they can stay in the right side and cause all those fibrosis. Serotonin is notorious for causing fibrosis. That is why someone that has this guy, what are we talking about? Um Pulmonoportal hypertension can develop, pulmonary hypertension. So someone that has a portal hypertension can develop pulmonary hypertension because the serotonin that accumulates from the body can get, to the lungs through those anastomosis. So they can get to the lung through the systemic circulation, and they can cause remodeling of the vessels um of the lungs. So causing pulmonary
Dr.
hypertension.
Orale,
Yes, Dr. Luciana.
please repeat what you said about this pulmonary hypertension, please.
In portal pulmonary hypertension, you have hypertension within the portal vessel. So that means that
Okay.
blood has to go back. And you know that
Okay.
there's a portosystemic anastomosis. That means
Mm-hmm.
that
Yeah.
it will go to the systemic component. When the blood cannot
Okay.
move through the portal, they have to go back and they will go and open those systemic collaterals. So by the time they
Okay.
get into the systemic collaterals, which is the systemic vein, all the systemic vein empties into what major vein.
All
I
the
just
The what? All the systemic
IBC, IBC.
IVC. So IVC takes you to the right side of the heart because the remodeling there. So that is it. So that's why they can cause pulmonary hypertension. Portal
Okay.
hypertension is a cause of pulmonary hypertension. Yeah. So they also contain neuroendocrine cells that stain for chromogranin A, just you can see here. So we should not forget that. Um, Pancreas tumor. Pancreas tumor is one of the complications of lung cancer, especially a cancer that is sitting on the apex of the lung. We call it the superior sulcus tumor. So the superior portion of the lung. Um, it causes this pancreas tumor within by compressing on the local structures, the structures that are surrounding that area. What are the structures that are surrounding that area? That is very close to the upper part of the mediastinum. So we have our aorta just coughing around that area. And remember that the left recurrent laryngeal nerve loops around the aorta at that point. So it can get compressed and the person can present with hoarseness of voice. The stellate ganglion is also known as the fusion of the superior thoracic ganglion and the inferior cervical ganglion. So it's located at the region of like C8, T1. So that area is also very close to, just around here. It's very close to the apex of the lung. Now, that stellate ganglion, I think I need to show us an image so that we can appreciate what we are talking about. It allows passage of sympathetic trunk. Stellate ganglion. I don't like this image that they are showing, Sha. Ah, okay, let's just manage this one. So, guys, now this is the stellate ganglion that we can see here. Hmm? Can you guys see this? You can see this. Hello.
yeah,
Yeah, we can.
yeah.
Yeah.
So that's telling someone is already yawning. Dr. Zulia is already yawning. Sorry, Dr. Zulia.
No, make it. I'm in the morning. No, Johnny, Bawo, Musha Beradin.
Maybe that's Dr. Oluwatobi. Dr. Oluwatobi is always jacking. So probably she's the one that is
Let me
participating.
just report myself. I'm the one who was young.
Because the Bangla is always working and
Yeah,
jerking
that's true.
too.
That's true. So she's justified. Yeah. So this apex, very close to that stellate ganglion. Now, this stellate ganglion actually um contains sympathetic trunk. Now, it's paining me that okay, I'm going to send the image to the page later. So there are some sympathetic trunk that are actually coming from the hypothalamus. They come down in the neck and they anastomose at one region that we call the ciliospinal center. So from that ciliospinal center, they move and they pass through the stellate ganglion. From the stellate ganglion, you have the last fiber moving up, to go to the eye. which is a long ciliary nerve. Now, my point there is that that stellate ganglion that we are seeing here is a combination of two things. It's a combination of the lower cervical ganglion at the level of C7 or C8 now, and the upper or the first thoracic, ganglion. They join together to form what we call the stellate ganglion. So it allows, passage of this. It's actually, anastomosis with the sympathetic fiber. Ganglion is like collection of cell bodies from something, from some fiber. So your sympathetic fibers have their cell bodies here, form this ganglion, and they move upwards to go to the eye to supply the entire face. Now, part of the sympathetic fiber that supplies the sweat gland of the face pass through this portion. The sympathetic fiber that supplies, the superior tarsal muscle pass through this ganglion. So someone that has compression of this stellate ganglion will have manifestation of ulnar syndrome because you have compressed the sympathetic trunk. So how will they present? Now, the first presentation, meiosis. So meiosis, because we know that the pupils, they have the parasympathetic and the sympathetic, innervation. Once the ciliary muscle, not ciliary muscle now, once the sphincter pupillae or the dilator pupillae. So the dilator pupillae is one that dilates. They are the muscles that surround the pupil. The sphincter pupillae is one that constricts it. The dilator pupillae is one that dilates. So dilator pupillae receives sympathetic. Sphincter pupillae receives parasympathetic. So once you have a parasympathetic stimulation, you have contraction of the sphincter pupillae, you have constriction of the pupils, and there is meiosis. When there is innervation from the sympathetic component to the dilator, it dilates. There is myodrasis. So someone that has problem with the stellate ganglion, you have cut out that sympathetic stimulation to the dilator. So that dilator cannot dilate. So the action of the parasympathetic component becomes unopposed. Then you have meiosis. That's why you can have meiosis in ulnar syndrome. Now, this sympathetic trunk also supplies the sweat glands that are in the face. So once you have truncation of this ganglion from compression of the lungs, then you cannot supply the sweat gland of the face. That means you cannot sweat again. So the person will have anhidrosis of that side of the face. That side. You guys know that it's bilateral. You have stellate ganglion on the right side, stellate ganglion on the left side. So instead the gland on that side of the face is, is problematic. So they have anhidrosis on that side. They have meiosis on that side. Then, what else are we going to talk about? Also, um, what other manifestation of other symptoms do we know? Ptosis, right? We're not talking about ptosis. So, ptosis because of the fact that you know that the muscles of the upper eyelid, they contain two things: the levator palpebrae superioris as well as the superior tarsal muscle. What supplies the levator palpebrae? Anybody? Levator palpebrae. What supplies it? Do we remember from our neuro?
Cranial nerve
Sympathetic.
Yeah.
3.
Cranial nerve
Oh,
3. Cranial nerve 3. Oculomotor nerve.
three.
Yes,
Nerve, oculomotor nerve.
exactly. So oculomotor nerve palsy can present with ptosis. Now, apart from that levator, there's another muscle that is there that we call the superior tarsal muscle. That superior tarsal muscle receives sympathetic innervation. So when there's damage to that sympathetic trunk, you cannot have activation of that superior tarsal muscle. You cannot elevate the eyelid. So you have a partial ptosis. You have a ptosis too, although not as severe as what we have with the oculomotor nerve. You have a ptosis, you have anhidrosis, you have um, meiosis. So those are the features of Werner syndrome and due to compression of this stellate ganglion from the Pancoast tumor. So what else can they have? Because of the fact that at that region you have your SVC. SVC is also one of the mediastinal content that is located superiorly at the region of that lung. So the SVC can be compressed. Now, if there is compression of the SVC, there's this way they will present. It will be bilateral because SVC takes in blood. It's a common pathway to empty blood into the heart. But it is taking blood from both the right side of the body and the left side, especially the head and the neck and the upper lips. So from the head and the neck, they are being drained both right side and left side by the right and left internal jugular. The right and the left upper limb are being drained by the right and the left subclavian. So the right and the left subclavian and the right and okay, no, let me take it one by one. So the right subclavian and the right IJV, they are going to join together to form a brachiocephalic vein, right brachiocephalic vein. The left internal jugular and the left subclavian are going to form the left brachiocephalic vein. So your left brachiocephalic vein and your right brachiocephalic vein joins together to form a common vein, which is the supravena cava, that now empties into the right atrium. So that means that if you have compression of the supravena cava, you have a bilateral congestion. So you have impaired venous drainage on both the right side and the left side of the upper limbs, the lower upper limbs, as well as the head and neck. So the person will present with venous congestion of the head and the neck, and there will be cyanosis. So there will be, cyanosis. They can have facial plethora. That face will just be red. The mouth will be blue. Um, um, what else can they have? They can have laryngeal edema. They can have pharyngeal edema in the head, in the neck rather, because all our pharyngeal veins, the laryngeal veins, they empty into the internal jugular and the supravena cava, the subclavian. So because of that, you have laryngeal congestion, pharyngeal congestion, facial congestion, upper limb swelling, bilateral. And when you try to blanch it, it's blanchable. That means you can separate the blood from the capillaries. So it's different from when you have a lymphedema. It doesn't blanch. It's a lymphatic. So that means you are having blood, accumulating there. That's what you have in the supravena cava syndrome. It can also be possible from a pancreas tumor. SVC can be compressed by a pancreas tumor. Brachiocephalic vein too can be compressed by a pancreas tumor, but in that you have unilateral symptom. So it's different from SVC. They will have the same presentation, but it's just that in brachiocephalic, it will be confined to one side. Because brachiocephalic on the right has to combine with brachiocephalic on the left so that they can form the SVC. So we should be able to picture why it will be bilateral with SVC and unilateral with brachiocephalic. Okay, so the brachial plexus too can be affected. So if the brachial plexus is affected, it is actually the lower trunks of the brachial plexus that will be affected. CHT1. So guys, if someone have compression of the CHT1 of the brachial plexus, what's the presentation? Guys, how the person present?
Clunky
Is that
palsy.
CHT1 of what? Sorry, I didn't hear the
Of the
question.
brachial plexus.
The
Yeah,
whole now.
fantastic.
Okay.
Okay, paralysis,
Exactly.
and
I'm
yeah.
coming down.